So we are looking at spinal examination for lower limb. So the patient has spinal stenosis at the lumbar region. So we will anticipate lower motor neuron lesion, and we want to do the tone, examine the tone of the lower limb. So how will we examine the tone? So this is not a definitive matter. No, so this is not a definitive examination of it. So usually when we want to examine for tone, we'll just do a test where we roll the leg, or we lift and drop. Okay. So there's one way to do this subjectively. You can keep this in mind when you're doing this. This is a good way to analyze the tone. So the first thing is, when you're rolling, first roll slowly. Let's do in this limb first. So we'll go slowly by placing the palms on the knee. We go slowly, rotate slowly, internally and externally, and look at the movement of the great toe. And then we go fast. So in a normal physiology, in slow movement, in slow rotation, the great toe will be following the direction of the external and internal rotation here. So it will follow. The great toe will follow, it won't lag. And when I go fast, the great toe will lag with the movement here. That is in normal physiology. What about in hypertonia, which is expressed in upper motor neuron region? So in hypertonia, when I go slow, the great toe will follow the rotation. That is the same in normal physiology also, right? It's common in normal physiology. The change happens when I go fast, at a fast pace. So in normal physiology, when I go fast, the great toe will start lagging. But in hypertonia, the great toe will still follow. Okay? So always remember, it's always slow and then you go fast. What about hypotonia, in the case of a lower motor neuron region? So in hypotonia, it's all flaccid, right? So when I go slow, in normal physiology, when I go slow, when I rotate slowly, the great toe is supposed to follow. But in hypotonia, it will lag even in slow movement. When I go fast, it will still lag. So that is one way to look at the toe. The other way is to just hold at the knee and lift it and just drop. So in normal physiology, when I drop, the leg will drop fast and at the same spot. In hypotonia, that's it. It will drop fast but sideways. It will just fall sideways. In hypertonia, it will drop very slowly and at the same spot. Or in hypertonia, the moment I lift the knee, lift the leg, the ankle will also get lifted together. Hypertonia. So let's see how. So this is a patient with lower motor neuron lesion because she has a lesion below the level of L1. So in isolated lesion, spinal injury, isolated lesion means there's a compression at a particular nerve root. Maybe that is caused by a tumor, spondylosis, etc. You won't expect this in a complete cord lesion. For example, you get a complete cord lesion in CT. So the general idea is the spinal cord in adults ends at the level of L1. So any isolated lesion above L1 will present with upper motor neuron lesion. Any lesion below L1 will present with lower motor neuron lesion. So I'll anticipate lower motor neuron lesion in this patient for hypotonia. So let's see. So the first will be, so you can see, when I internally rotate, it's a slow movement, but the great toe is lagging. The great toe is lagging even in slow rotation. And even in fast, of course, it lags. That is self-explanatory. But even in slow, in normal physiology, in slow rotation, the great toe will be able to follow. But here it is lagging. And the next test I want to do is lifting and dropping. So in hypotonia, I would expect the leg to drop fast and drop sideways, which is evident here. So confirming that this is a lower motor neuron lesion and that the lesion is below L1. The isolated lesion is at a level below L1. Okay, so to specify the level of the lesion, we'll move on with the examination of power, reflexes and sensation, dermatome, myotome, reflexes and sensation.